Thank you very much, and it's great to be back. Tonight is the fourth week in our series. For those of you who've been with us, you know the last 3 weeks we've focused on bipolar disorder and depression. Tonight we begin the first of 2 weeks exclusively focused on schizophrenia. Tonight we'll talk about the illness, providing you the state-of-the-art understanding of the disorder. Next week we'll talk about treatment, and hopefully next week I'll be joined by 1 or 2 folks with schizophrenia who will just kind of share their story and be open to your questions as well. Following these 2 weeks, we will have 1 week on post-traumatic stress disorder. And then the final week of our series, which I invite all of you back, is specifically designed for families. How you as families, specific roles that you can do for your loved one to best help their recovery. Regardless of what disorder or illness we're talking about, there's helpful roles and skills that we want to impart for you. So tonight, again, we're going to focus on schizophrenia. And I think the best way to begin is to describe first one person's description of their experience of schizophrenia. Living day to day is a challenge because it is just simply hard for schizophrenics to live in the world that is so troublesome to them. My fears are so intense that before I do most things, I must pass through a wall of terror that stands between myself and my goal. Leaving the house, talking to someone, or taking a walk can create panic, simply because I do not feel like part of the world. It is a foreign place to me. Since my childhood, I felt like an outsider looking in. Schizophrenia is not just an illness, it is a way of life. And it is a life constantly disrupted by symptoms. So as that person's experience tells us, as we begin to talk about schizophrenia, the most important place for us to start is by understanding the personal experience of the person. Because we're not just talking about an illness for which there is a treatment and it goes away, or just a particular aspect of the person's life. But as we heard here, it can taint the person's entire life. And so we always want to begin by understanding that experience of the person. So as you hear about some of the technology and the science about this disorder, as we look into the brain to learn more about it, I invite you to take that information, not try and fit your relative into that, but use the information to help you better understand your relative and help you better help them in their recovery. So as we begin our journey these next couple weeks, I think about it in 2 ways. It's about education, it's also about hope. Education and hope. We're going to look in and understand the biological nature of this disorder. Biological at its basis. We're going to understand the causes and the course of schizophrenia. We'll look at the primary symptoms of the condition. And rather than just give you a list of those symptoms, what we're going to do is we're going to go into the brain. And as we journey through the brain, you'll see where the different symptoms occur because of an impairment in the brain. As we move into next week, we're going to talk about the 3 key ingredients in recovery. Number 1, medication is the foundation for treatment. Number 2, we're going to talk about the psychosocial rehab model. This is a model of treatment that best fits folks with major mental illness. And then following that last week, what I invite you all back for, is when we talk about all those helpful roles and skills that you as family members can provide. When we combine those 3 areas, the medication, the psychosocial rehab approaches, and the support that families, friends can provide, we provide the state-of-the-art treatment to best promote recovery for folks with schizophrenia. That last week, in addition to hearing about those helpful roles and skills, we'll also have a family panel to talk about their own experiences as family members in coping with this disorder and what helped, perhaps what didn't help them along that journey. So let's begin by talking about schizophrenia, or as you'll see on the heading of the slide, I've written the schizophrenias, plural. And why do I do that? It's not a typo. I do that because we really best understand schizophrenia as a group of related biologically based disorders. The more we learn and understand about schizophrenia, the more we see these variations in it. And it will appear different in different persons. And so we understand them as, again, a group of biological disorders. The hallmark symptoms, as you'll hear about, are hallucinations and delusions. These are what are known as the psychotic symptoms. Psychotic meaning that when there's this break from reality. So as we'll hear about hallucinations, these false perceptions coming into my brain that I believe are true, such as the voices, or the delusions, which are those false beliefs that the person may have. We know that schizophrenias produce permanent handicaps in thinking, learning, and social relationships. And again, we can see in the brain. So we want to be realistic to know that when schizophrenia hits, it's not something that we can just learn about and learn what went wrong and fix it. It's not something for which treatment can come in and in 12 weeks we're cured. It's something that we know will be a lifelong condition that we're dealing with. We do know, however, that while this affects 1 to 2% of the population worldwide, and while there is no cure, the new treatments you'll hear about can really improve the quality of life for the person. Important for us as we start to understand what schizophrenias are not. Because in past times, all of these things you'll see here have been misunderstood causes of the disorder. First, schizophrenias, all psychosis is not schizophrenia. Just because someone hears a voice does not mean they have schizophrenia. The last couple of weeks, we talked about bipolar disorder and depression. In severe states of mania or depression, persons can experience voices or delusions. Temporarily, as the result of trauma, folks can experience voices or delusions. There are some medical conditions, as well as drugs, such as cocaine, methamphetamine, during which people can experience voices or delusions. So, all that to say that just because that one symptom exists, we don't want to identify it as schizophrenia right away. Schizophrenias are not split or multiple personality. And this is a misconception that even comes from the name itself, schizophrenia. The word schizophrenia means split mind. And if we go back a number of years to the early part of the last century, split personality and schizophrenia would have been seen as the same thing. We certainly now understand them to be very different. Split personality, multiple personality, now called dissociative identity disorder. Much different. That's something that is typically the result of more severe early abuse. It is not a biologically based disorder. Schizophrenia, as we'll hear, biologically based, can occur regardless of childhood history, and we know it's going to hit typically late adolescence, young adulthood. Schizophrenia is clearly not contagious. It is not the result of some evil or sinful behavior by the person or by a family member. And perhaps most importantly on this slide, schizophrenia is not anyone's fault. Perhaps you came here blaming yourself, blaming someone else for this disorder. And I want to clearly state that schizophrenia is best understood as a no-fault condition. Allaying blame will only keep us stuck and prevent us from moving forward to recovery. And so if you came here or if you have some of that guilt in there, I invite you to forgive yourself. As we go forward tonight. And as you learn the information, hopefully it will aid in that forgiveness and help alleviate some of that guilt. Because what you'll see is the science behind this disorder and what it's really about. And lastly, schizophrenia is clearly not hopeless. When we talk about treatments, we know that there is a lot that can be done to help promote recovery for folks with this disorder. Now, some things that we go through in life are just biologically determined. And even when they come out, is biologically determined. So, for example, I have a 12-year-old son, and I know in these next couple of years, he's going to start experiencing a few changes. I'll probably start hearing his voice crack a little bit, right? Start getting a little of that acne on his face. He might show an interest in those girls that until now have just had no interest for him whatsoever. Now we know that as puberty. It's a natural, biologically based event that happens in everyone's life. It doesn't occur until the beginning of adolescence. Now, the precursors for it, the stage was set, if you will, in utero, that all of us hit puberty in teen. It's not that something happens when we're 12 that sets this in motion. So, in a sense, the programming was already there. So with biologically based processes or conditions, we can see there's probably a natural course that they take. And with schizophrenia, we'll see that it's no different. For schizophrenia, the average age of onset is going to be late adolescence into young adulthood. It is not uncommon, as this slide shows, that up until adolescence and into the teen years, folks can do quite well. Quite well. Worked with folks, graduates of Ivy League schools before this illness hit. Working out in the professional world before this hit. So it's a condition that doesn't require, again, the early dysfunction in the family, the abuse, that something you did as a parent was wrong and caused this. We can see that folks can be quite successful, doing quite well before things start to hit. The typical course will be in adolescence, what we're going to call this prodromal phase. We'll talk about that more in a minute. Things start to slide just a bit until the onset of the condition, those first psychotic symptoms, the first real devastating symptoms. And what will often happen is when those first hit, we get this dramatic deterioration, from being in school to being on the street. Often the onset leads to that first hospitalization. And that's what we see at the low point here. So again, typically late adolescence, early adulthood. Untreated, again with no treatment whatsoever, we know this will be a persistent, recurrent disorder that throughout the adulthood we'll see some partial stabilization, if you will, and relapses. And that's just going to continue. Untreated, that's what we know will happen with this disorder. In older adulthood, it may mellow out a bit in terms of those real drastic psychotic episodes. But we know the functioning is not going to be greatly improved if we don't provide treatment. Again, I want to echo that this is the course of the illness without any treatment. And what you're going to hear about next week is how we can change that course. How once the illness hits, we can actually do things to start bringing this curve up. How we can do things to prevent the severity, the frequency of those relapses. So there's going to be a lot we can do about it. But I point this out again, just so you can understand this biological course that the illness has. We know that schizophrenia is roughly 50% genetic. Roughly 50% genetic. The other 50%, lots of different factors that play into it. A lot of biological factors. Research looks at things that happen in utero, perhaps at birth. Other biological or environmental stressors which can happen throughout childhood and into young adulthood. So research is looking to see what those other factors are, and there's many of them. But how do we know it's roughly 50% genetic? Well, we know that schizophrenia follows the genes. So, studies look at family relations. And we know that in families where there are identical twins, now identical twins carry the same genes. And we know that when identical twins, if one twin has the illness, roughly 50% of the time the other twin will have the illness. And this has been shown even in studies where identical twins were raised apart. So we know it's not just the family. We know that even when they're raised apart, we see this roughly 50% rate. Again, if both parents have schizophrenia. Roughly 50% chance the person will have the disorder. So this is where we get that, that understanding that schizophrenia is roughly 50% genetic. Now, as the genetic link becomes weaker, so does the likelihood of the disorder. One parent, one sibling has the disorder, we're down to 12%. A secondary degree relative, an aunt, a nephew, a grandparent, now we're down to about 5%. We go out one step further, a cousin, a great aunt, down to 2%. And we know that even with no relative, that 1% of the population will have this disorder. And we can understand that because we know when we see, for example, with both parents having the disorder and it leading to the illness, it tells us that the person will experience the impact from both sides of the family. And it's a very kind of complex interaction of genes that lead to the disorder, but it is through that interaction where it happens. Which is why, even in a family where no parent, no history we can at least see or know of with the disorder, that complex interaction of genes from both sides can still be the precursor for getting schizophrenia. It's important to know that stress, environmental stress, the stuff we deal with every day as part of life, that alone cannot lead to schizophrenia. Folks with a very strong genetic predisposition, both parents, the identical twins, even in the absence of a strong psychosocial factor or stressor, that alone can lead to the illness. Weaker genetic predisposition with some of those other stressors. Again, some of them could be biological, some things that happen in utero, as well as with the environmental factors. You combine all of that, we can lead to schizophrenia. No genetic predisposition whatsoever. Regardless of the stress, we're not going to see schizophrenia. We'll certainly see lots of other things. We'll see lots of depression, anxiety disorders, post-traumatic stress, substance abuse disorders. So we're going to see lots of those things. But we're not going to see higher incidences of schizophrenia. We'll go back and even look at research. Folks in concentration camps during World War II certainly experienced lots of difficulties after that. Not higher rates of schizophrenia. Higher rates certainly of many, many other things, as you can imagine. So again, allow this information to help you understand that at its roots, schizophrenia is a biological and genetic illness. So as I mentioned, the illness typically hits late adolescence or young adulthood. And so we understand, well, why is that? Why is it then? Why not 40? Why not 60? Why not? We're born with it, we see it right from birth. Well, what we know from research is that the onset of the disorder starts with something going awry in the brain during what is called the cortical pruning process. That's one of the few technical terms I'm going to throw out at you tonight. Cortical pruning, if we break it down, is really quite simple. Cortical refers to the cortex. The cortex is our brain, the brain structure. Any of you with a garden, you know what pruning is. You go in and you prune. You remove the weeds so that your plants can grow stronger. In our brain, in adolescence, there is a natural process of cortical pruning which occurs. Now, why is that? Well, from birth through adolescence, the brain grows like wildfire. It just grows and grows, and neurons are being built, connections are being made. So as we're hitting adolescence, it's becoming almost like that overgrown garden. And so our brain, in its wisdom, knows that there needs to be this pruning that has to occur, just like in your garden if it becomes overgrown. And so what the pruning does is it removes the weeds, if you will, the neurons and the connections that are less important. And it does that Again, just like in your garden, because you want the important ones to grow stronger. And in the brain, we want the important neurons to grow stronger. What we'll see here is what happens in cortical pruning. On the left, you'll notice this is if you will, a simplified picture of a normal neuron. And actually, it almost looks like a plant in your garden, doesn't it? The bulb that's there underground, a strong root coming out. And that's what we might see in a normal, healthy neuron. And with the pruning process, the weeds have been kind of pulled away, if you will. But when that process goes awry, what happens? Well, we're going to see tangled up neurons. We're going to see damaged structure, broken neurons. Imagine your prize-winning rose garden, and now you ask your 7-year-old nephew to go in and do the pruning for you. And imagine what's going to happen. Right, you can guess. Some of the roses are going to be on the ground, and some of those weeds are still going to be there. The process goes awry. It goes awry. And this is what we'll see in the brain. Again, you can see the picture, the tangled neurons, the broken neurons. But simply, this is where we'll see the functional damage of schizophrenia. Functional because we'll see the parts are all there, but they're not working correctly. And here, we'll see more severe kind of structural damage, where some of the parts, if you will, are now missing. This occurs, again, in adolescence. And when this process is healthy, then we move into adulthood, healthy brains. And they're working the way they should. And our brains will keep growing, and we'll keep learning throughout the lifespan. But this pruning process in adolescence really sets the stage for that to happen. And when it goes awry, we see the onset of mental illnesses like schizophrenia, like bipolar disorder. What's challenging is that the early part of this disorder happens in adolescence. And if I look at some of the early signs of the disorder, and these first signs occur what we call the prodromal phase. Prodromal is before the condition actually exists. So we would never diagnose someone with schizophrenia when they show these signs, but they are potential precursors to it. Signs like insensitivity to others, social isolation or anxiety, poor peer relationships, emotional lability, which is that fluctuation in moods, behavioral problems in boys, difficulty focusing, concentrating. Now, as you look at that list, you might think, well, gosh, that describes pretty much every teenager I've ever met. Right? They go through all of this stuff. So how do we know the difference? How do we know the difference between this and what will later move into schizophrenia? Because as we go forward, we'll start seeing signs that are going to be a little bit more indicative of the condition. Flat affect, kind of just that kind of the blankness, the lack of real emotional expression that's there. Perhaps some real odd behaviors, magical thinking, things that sound a little bit off, but you wonder, is it just imagination, or are they really believing this? And just some unusual perceptions. You know, I got on the bus and I looked over and there was someone sitting there. I just looked again and there wasn't, so I just kind of shake it off. Right? We just think, okay, I just had a little lapse, but things like that will start happening. And these are going to be the precursors that will lead into the disorder. What can make it difficult is that we don't see those early signs often. What we first see are the results. We see poor performance in school, problems with peers. We'll see alcohol and drug use, conflict at home. And when we see those things, and those lead to that first episode of schizophrenia, it can lead us, mistakenly, to conclude that that's what caused schizophrenia. Countless times, folks have told me that my schizophrenia was caused by a breakup. It was after that breakup I had with my first girlfriend, my freshman year of college, that's when it hit, and that's what caused this to happen. Or I took way too many courses, I got overloaded, and that's what happened, and that's why I got this illness. And in time, those things make sense because one happened and then the next. However, just because two things happen in time don't necessarily mean one causes the other. Any of you who are sports fans know that your favorite athlete probably has some rituals that he or she does. If they wear a particular pair of socks that day and they get 4 hits in the game, they're going to wear those socks the next day. Now, we know the socks didn't cause them to get the 4 hits, but let's not try telling them that. They're going to keep them on the next day. What's missing in this story is what's really playing into it. And that is those early signs of the disorder that I was just described to you, that those set the thing in motion. And as a result of those things being in motion, again, small, subtle changes, but changes that will lead to me having difficulty in my relationships or with school, with my emotions. Maybe I turn to alcohol or marijuana to try and manage these things. Right? And then we get the problems, and then we see the illness. And so it's important to recognize that there are these early signs, often unnoticed, undetected. And again, signs that, even if we see them, right now, we wouldn't start treating the person for schizophrenia, because it's not schizophrenia. And oftentimes those signs may lead to something else or not lead to schizophrenia. What they would invite, though, is just getting help and getting support, because that can alleviate and be ready if, in fact, the illness does onset. So right now, there's nothing we can do to prevent schizophrenia. Hopefully in the years to come, we'll be able to move more in that direction. But right now, we're just not able to do that. One of the other things about schizophrenia that's important to know is that the worst damage from the disorder will occur in the first 5 years of the person having the disorder. What's especially sad about this is that if I said the time that the person is least likely to get any help is going to be the first years of the disorder as well. And so it invites us to really be cognizant and know that the earlier we get in, the earlier we provide treatment, what we're doing is we're helping prevent the severity of the disorder. Untreated, we know where the disorder goes. We get in and provide good treatment, and if we can provide it soon, then it really gives us a better outlook and greater hope and greater possibility for the person. Schizophrenia is what we call an autotoxic disease. Alzheimer's is an autotoxic disease. Autotoxic meaning automatically poisonous. The brain, in a sense, starts working against itself. And untreated, as in Alzheimer's, the brain starts acting against itself. And schizophrenia does that. It's working almost against itself as the damage gets worse in those earlier years of the disorder. So again, we get in and we provide treatment. We're kind of stopping the illness in its tracks. We can't reverse anything, reverse the illness, if you will. We kind of stop the deterioration, if you will, in its tracks. So that know that the severity of damage can be lessened if we get in there early and provide the right treatments for the person. And then lastly, again, may sometimes be preventable. Won't go into all the research around this, but the research at least is showing us that if we can identify those early signs, in fact, research studies have done that where they've been into small communities and been able to have all the healthcare providers in that community refer folks to their study who had the early signs. And most of them were factored out right away. But those who showed some of those signs of schizophrenia, when provided with some of those treatments in a research setting, what they found is in communities they were able to lower the incidence or the expected incidence of schizophrenia. And so it kind of says, okay, if we get in there early, that we can make a lot of difference. Ultimately, perhaps in a generation or so, we're going to see that the real prevention of schizophrenia can only happen in utero, because we understand that's where it gets set in motion. And so again, maybe in a few generations from now, our research will advance to the point where we can actually do some interventions in utero to prevent this. But that's a hope. That's a hope for the years to come. So let's move away from the cause and the course of the disorder and start looking at the symptoms of schizophrenia itself. And what's helped us do this has been our ability to study the brain. One of the things that's made studying the brain very difficult is that in our bodies there is a filter known as the blood-brain barrier. Now, blood that gets pumped out from the heart goes throughout the body. And it goes to the lung cleanses it, puts oxygen in, etc. But because the brain is so important, right, it's like command central, that it has extra security. And the blood-brain barrier is like the extra security for anything going up into the brain, including the blood. So there's this filter that filters out, so it in a sense changes a little bit of the blood going into the brain. So if we wanted to really study the blood that's actually in the brain, we're really not able to do that. Because of course it just makes logical sense that we would not put a needle into our skull to try and extract blood. Whereas we would do that in other parts of the body without much concern. What's happened, of course, in the last 20 to 30 years is the advent of the brain scan. And with the brain scan, with that technology, now we can go into the brain and see what's happening. We can see the structure of the brain, we can see the functioning of the brain, we can see what's going on in the brain when we're given a task to do. We see areas that activate too much, those that don't activate enough, and it helps us understand these conditions. So as we journey into the amazing brain, tonight we're going to look at 4 key areas that are implicated in schizophrenia. We're going to look first up top at the frontal lobe of the brain, where we'll see the executive functions of the brain. Then we're going to move down along the side. You see the temporal lobe. And the temporal lobe is where the hallucinations and delusions occur in the brain. Then we're going to look at 2 other sets of structures that are a little deeper into the brain. One is the limbic system, the other, the basal ganglia. And as we look into these, what we'll see are the different symptoms of the disorder evidenced in those areas of the brain. And important to just keep in mind as we do this, that it's understanding the disorder is not as simple as, I can just look at this area of the brain, I see it, and we can diagnose. We're not that sophisticated yet where a brain scan can be used by itself to diagnose a mental illness. The clinical assessment you get from a trained provider is still the best way to diagnose the disorder. Brain scans and the like can be helpful in aiding some things and aiding in treatment, but the diagnosis itself, again, right now, will still come from the trained clinician. And as we understand what's going on in the brain, one of the analogies I like to use is that of architecture. In that, to understand the architecture of a building or of a house, I look at all the pieces and how they fit together. I don't just look at a door and conclude the architecture of the entire house. I have to see how it fits in with the design of the house, the windows, are there columns, the roof design, all of these things that I see, how it all fits together. And it helps me understand the architecture. Much like as we begin to understand the symptoms of the condition, I can't look at one particular symptom and diagnose the disorder. I have to look for a pattern of things and how they all work together to lead me to make that accurate diagnosis of the disorder. So let's look a little bit into the brain. And as we do this, we are going to look at, again, those 4 areas, and we're going to start by looking at the frontal lobe of the brain. And so as we look here, you can see here's the entire brain, and I'm going to hone in here on the frontal lobe for us. And there you see it shaded. And the dark there is called the prefrontal cortex. And that's going to be the most important part of our brain in terms of being human. Because this is the part of our brain that separates us from every other animal in the kingdom. Is this amazing development in our prefrontal cortex. And so let's take a look at what happens and what that prefrontal cortex will do for us? Well, the frontal lobe, prefrontal cortex, all dubbed the executive, because all what are known as the executive functions occur here in the frontal lobe. So executive, think of the executive in a business or the executive in a family, right? The one in charge, the one responsible for all of what you see here. Drive and ambition, problem solving, ability to plan, multitask, show good judgment, have empathy, organize. The ability to think abstractly, right, in models and metaphors and stories. Our working memory. These are all things that are tasks of the frontal lobe that we're going to see impaired when we look at schizophrenia. As we start looking at these things, I invite you, when you go to work tomorrow, to evaluate the frontal lobes of your supervisor. Because a good supervisor needs to have a good frontal lobe in the brain, right, to do all these tasks that you're going to see here. In very severe cases of schizophrenia, we'll actually see missing structures of the frontal lobe. This would be the worst 1% of schizophrenia. A person with this severity of damage, because what we're seeing here, you usually see this kind of rounded shape. We see this structure of the brain where it's missing. We see missing parts of the frontal lobe. Someone with this severe of a disorder would probably be institutionalized for life, because there's really very little treatment can do if there's that much damage in the brain. Fortunately, the vast majority of folks with schizophrenia do not experience this level of structural damage. If there's any real structural damage at all, most will experience what is known as functional impairment. And by functional, I mean the parts are there, they're just not working correctly. And medication can do something about this, whereas even medication can't do a whole lot if there's missing brain structure. So what you're looking at here is a PET scan. PET scans show brain activity. When you look at a PET scan, the lower end of the spectrum, red, orange, yellow, that indicates a high level of activity. The other end of the spectrum, green, blue, purple, indicates lower level of activity. I invite you to focus on where the arrows are pointing, which is the frontal lobe. It's kind of a top-down view of the brain. You see the frontal lobe. On the left, person given a task, person without a mental illness given a task. Or perhaps you as you're focusing in on this lecture tonight. What we really like to see is what I'll dub that fireball of activity in the brain and in that frontal lobe. Because what's that fireball telling us? That's saying lots of activity. Right? The brain is expending a lot of energy in that frontal lobe, which is where we want it to happen. Because the frontal lobe is going to, as you are doing right now, take in information, try and process it, perhaps apply it to your loved one. What can I do that might be helpful, right? You're thinking, you're taking things in. That's a good frontal lobe. And in fact, when that's happening, ideally, other areas of the brain can be a little quieter. Because we don't want to be distracted, we want to be able to focus in. On the right, we see untreated schizophrenia. And again, you look up here on top, and what's clearly missing is that fireball of activity. So what is it telling us? It's just telling us that frontal lobe is just not firing, not activated, as we'd like it to be for someone with schizophrenia. So you have the most amazing idea and suggestion to give to them about how to do something, and they don't follow through with it. Your suggestion wasn't because it wasn't amazing. It's because their brain's just not able to fire and not able to make it work. Think of what it would be like in school or in a job if this is what's happening. Right? Why it would be so difficult, and why we would see problems. Of the many symptoms we'll see that happen in this frontal lobe, one of the more frustrating can be that lack of insight, which is known as anosognosia. Fancy word there, anosognosia. And when someone has a lack of insight, our first reaction might be, this is denial. Certainly from the language and the world of substance abuse and addiction, we hear a lot about denial. So you might think the person is in denial. Or they're being resistant. You just don't want to listen to me. You don't want to understand. You're being stubborn. Natural human reactions in the face of what was probably initially presented to us. The person who sits in their room all day and tells you that they're just tired. What do you mean you're tired? How can you be tired? As we'll see a little later, we'll see what's going on in the brain when they're actually, what looks to us like resting and doing nothing in their room. The brain's still going and going. Javier Amador has a wonderful book called I'm Not Sick, I Don't Need Help. And he's the one that really did the research to find that in the frontal lobe of the brain, we can see the symptom of anosognosia, or the lack of insight, so common in this disorder. So we can look in there and see it, and again, we want to understand that it is symptomatic of the condition, as opposed to just a personality trait. That being said, folks with schizophrenia can be just as stubborn or lazy as you or I can be. So it doesn't take away that or remove that, but it does say that that's not the sole thing of what's going on here. That in the brain, there's the lack of insight as a result of this disorder. A few other things that occur as a result of the impairment in the frontal brain. Concrete thinking. Concrete thinking. I hope most of you can remember Dennis the Menace. He's not as popular as he once was. But here's a slide, and in this particular example here, Dennis has got his wagon, and a couple of the wheels fell off. So he's got him there, and he's carrying it over, and he tells his dad, I'm taking it over to Mr. Wilson's. He said, the next time I come over, he's going to fix my wagon. Now, Dennis didn't quite get what Mr. Wilson had in mind, did he? Dennis just took that literally, concretely. I heard him say he's going to fix my wagon. My wagon's broke. I will take it over there. He's going to be in for quite a surprise when he gets there. This concrete thinking occurs when the ability to abstract, the frontal lobe process, gets impaired. So, for example, one person's told me a story how they went into work. They were supposed to be there at 9. They arrived at 9:15. The boss looked and said, it's 9:15. The person looked down at their watch and said, yes, you're correct, it's 9:15. Did not take into account what the person was really saying. Hey, it's 9:15, you're 15 minutes late. Next time be on time. Didn't get all that. Just heard concretely, yeah, it's 9:15, you're right. That's right. Another way that this comes into play that's a little bit more frustrating is when we start talking about medication. Oftentimes folks will start taking medication and they'll stop. And why will they stop? One of the reasons is, well, I felt better, so I stopped. Now, concretely, that makes absolute perfect sense. If you have a headache and you take 2 aspirin, your headache goes away, you stop taking aspirin, you don't keep taking it. It makes sense, doesn't it? Now, it also makes sense if you're a diabetic and you take insulin and your blood sugar's at a good level, hopefully you keep taking it. Because if you stop because you're feeling better, good chance you're going to be in the ER pretty soon. So what do we see here? 2 different conditions requiring different ways of approaching them. One, I take a medication, I get better, I stop. The other, I take a medication, I get better, I keep taking it. I have to recognize there's an ability to abstract and see those differences. And so again, we don't want to just get mad if the person stops. And sometimes we'll use analogies like diabetes, like blood pressure, to help understand that this is just kind of a normal part of it. That if you're feeling better, that means it's working. Great. Let's keep doing that. Let's affirm that. And let's keep going. One other example is complex working memory. Now, working memory is the mental scratch pad that's in our brain. What do I mean by that? I give you a phone number, right? Your brain, for 30 seconds or so, you can hold on to it enough that you can jot it down. So things like that we can do. If I gave you something too complex, it'd be pretty hard to do that. But for about 30 seconds, my brain has this kind of mental scratch pad, like a little sticky note. And it decides after 30 seconds, is this important? And if it is, it's going to go into memory. And if it's not important, I filter it out. It's another part of the brain that'll filter it out. We'll get to that in a little bit. But when you drove here tonight, your brain was bombarded by stimuli. You probably don't remember how many lights you had to drive through to get here. You probably don't remember what the billboard said on your way here, unless there was one that really stuck out at you. You saw those, but pretty quickly your brain decided not important. Things you decided were important, they're probably still in there. So the working memory, the mental scratch pad. We do a test. I give you letters and numbers and I say, your task is to reply with the numbers and then the letters in order. So I say to you, 6, R, G, 3, 8, T. All of you, I'm sure, would astutely respond, 3, 6, 8, G, R, T. That's the type of task that our working memory can do for us. Good frontal lobes can do that for us. Schizophrenia, we're going to see this greatly impaired. So again, think about it. I'm trying to learn a new task. I'm trying to listen and take notes in school. That ability to kind of just hold on to that stuff long enough to know it is important and take notes is going to be impaired. The boss says, here, this is how you get the job done. First you do this, then you do this, third thing is that. Okay, got it. Go off. Okay, I know the first one, I can't remember what those other two were. Got to be impaired with schizophrenia. The misunderstanding in social situations can also occur here. I'll give you an example. And also how you can see how it leads to very bizarre behaviors, because the behavior will make sense to the person in this example, but to the outside world, it will not. A woman with schizophrenia who deeply loved her mother and longed for a visit wrote, during her visit, I tried to establish contact with her, to feel that she was actually there, alive and sensitive. But it was futile. Though I certainly recognized her, she became part of the unreal world. I knew her name and everything about her, yet she appeared strange and unreal, like a statue. I saw her eyes, her nose, and her lips moving, heard her voice, and understood what she said perfectly. Yet I was in the presence of a stranger. To restore contact between us, I made desperate efforts to break through the invisible dividing wall. But the harder I tried, the less successful I was, and my uneasiness grew. So I reached out, and I pinched her to make her real to me. But then the nurses took her away and left me alone. The nursing note for that visit read, patient hostile towards an attacked mother, advised mother not to visit. Drastic consequences if we misunderstand the behaviors of the person. To that woman, it made sense. One person with schizophrenia said they wanted to get plastic surgery because it felt like they had this layer of plastic around their whole body. This difficulty connecting with the world, interacting with the world. You heard that in that example with that woman. I don't feel the connection with her. She's there, out there, I can't feel the connection. So how do I make her real? I'll reach out, I'll pinch her. That'll make her real. I'll touch her, I'll connect. But doing that in a way that was misunderstood. We can understand that, right? Those behaviors, violent behaviors, that may make sense inside the world of the person. But to the outside world, it can be very, very challenging and very difficult for us to deal with. And oftentimes we do have to really just deal with those violent behaviors and take them seriously and make sure the person is safe. I'm not saying we don't need to do that. We certainly do. One other way we test abstraction is proverbs. So if I give you the proverb, people in glass houses shouldn't throw stones, you may have an idea what that might mean. But if I'm very concrete in my thinking, I would tell you, well, it would break the environment. One person said that. Another person who's just very disorganized said, well, people should keep their decency about their living arrangements. I remember living in a glass house, but all I ever did was wave. Someone else who had a real awareness of the feeling, but without understanding the concept, simply said, caution. So as you can see, it can be impaired in different ways, but when that frontal lobe is impaired, those executive functions are impaired. And that ability to really function and interact in the world is greatly impaired. So I'd like to start with the frontal lobe. Even though those hallmark symptoms we're going to be talking about in a few moments, hallucinations and delusions, I'd like to talk about the frontal lobe because I think it really sets the stage in terms of our understanding that when that's impaired, that ability to interact in the world and even how I'm trying to cope with what's going on with me is impaired by this disorder. So with that, we're going to take a short break. And we're going to move forward now into the next area of the brain, and that is the temporal lobe. Temporal lobe, pretty much right here behind the ear on the side of the brain, as you'll see here in this picture. These structures down here. And what do we know about this part of the brain? What is it responsible for? Well, the temporal lobe I'm going to dub the reality checker. So we've got the executive, and now we've got the reality checker. And the temporal lobe is responsible for perception, reality orientation. It's also involved in memory. Perception, what we perceive from the outside world through the five senses. Misperceptions are what are known as hallucinations. A misperception of the senses. I hear something which is not there, commonly known as the voices. It can occur with any of the five senses in schizophrenia. A visual hallucination, seeing something not present. Somatic hallucination. I feel something. There's bugs on my skin, crawling on my skin. I need to get rid of those. Olfactory, which is smell. I can smell things which are not present. Or even gustatory, or taste. These sensations of taste when there's nothing there. By far the most common is the voices. Visual hallucinations are more common when there is drug abuse going on. So when I hear someone say there's visual hallucinations, it does at least perk my radar to be looking more for substance abuse, although it doesn't necessarily have to be there. Reality orientation. When my orientation to reality is off, the symptom we see is called a delusion. Delusion, a fixed false belief that I hold my perception of reality. No one else will hold, but I believe it to be true. Let's look inside the brain again and look at a more severe case of the disorder where we see the structural damage and the two arrows. You may barely see them, but the two arrows are pointing here to these dark spaces, these cavities. Fancy term is enlarged ventricles. An enlarged ventricle is an enlarged opening or gap in the brain. Well, what's the problem here? The problem is that there's supposed to be a structure there and it's missing. And so we've got space where there should be a brain structure, as you can see on the left side, where there is no illness. In the healthy brain, there are ventricles, there are openings. Right? It's not a solid mass. There are these cavities, almost like a sponge. But when they're too large and missing, you'll see what's called enlarged ventricles, and it's one of the symptoms, one of the things of the disorder. Now, as I mentioned, most commonly, we're not going to see this level of severity. This is just in the worst cases, but from a research perspective, it does help us understand the illness. More commonly, it's going to be the functional damage. And so what's happening? Functional. What's going on in the brain when the brain is saying, I hear a voice? The person is saying, I'm hearing voices. We're going to look at two parts of the brain. The temporal lobe, which we're talking about right now, is where the brain perceives that sound from the outside world. And once that's perceived, temporal lobe perceives this sound coming in, it sends it off to the frontal lobe. The frontal lobe's job is to make sense of it. Right? We talked about the frontal lobe as the executive, the part that really thinks, if you will, and makes sense of things. And so the frontal lobe will make sense of this sound that is coming in. So let's first look at when there's no schizophrenia, when there's no mental illness. Right now you hear my voice. What's being activated? Well, your temporal lobe is being activated, perceiving the sound coming in. Sends it off to the frontal lobe making sense of what is going on. So you hear my voice, temporal lobe, frontal lobe, both activated, healthy. When you are just thinking, so I say to you for the next 5 seconds, I'm going to be quiet. I'd like you to think about one thing that you have learned so far this evening. So for that 5 seconds, your temporal lobe calmed down a bit because it wasn't perceiving any sound coming in, wasn't focusing on that. But your frontal lobe was working because there was a task. You were thinking about something. And that makes sense. So when we're thinking, just the frontal lobe is going. Let's look at schizophrenia. Hearing this lecture, hearing my voice, person with schizophrenia, what happens? Well, temporal lobe perceives sound coming in, sends it off to the frontal lobe. Frontal lobe does its best to make sense of it. As we just saw earlier, certainly when it's untreated, it's going to be impaired in its ability to make sense of it, but it's going to hear my voice and try and process it just as anyone else. The kicker in all of this, when the person with schizophrenia is hearing voices, to us, to the outside, there is no sound going on, but they are perceiving sound. What happens? The temporal lobe is activated. It is perceiving sound coming in. The brain is saying, I hear a voice. And then it sends that message, it sends that information off to the frontal lobe to process and make sense of it. The temporal lobe misfiring, activating when it shouldn't, setting that information off. This is why we can't just logically try and explain that there's nobody there. Right? Someone who maybe doesn't have the full insight or the awareness of it. Or sometimes even if they do have an awareness of the disorder, to try and just say, there's no one there, look around. There's no one speaking. There's no one there. Because that other part of their brain is saying, no, I'm hearing this voice. This is what I'm hearing. This is what's happening. There's often an expression, don't confront a hallucination, don't confront a delusion, because it can invite more tension, more conflict. Because to the person, this is a very real experience. This is what's going on in the brain. The frontal lobe is activated. Helps us understand this. Let's talk about delusions and their core qualities. Let me first read to you one person's experience of what schizophrenia was. And we'll see how some delusional belief will come into play here. What then does schizophrenia mean to me? It means fatigue and confusion. It means trying to separate every experience into the real and unreal, and sometimes not being aware of where the edges overlap. It means trying to think straight when there's a maze of experiences getting in the way, and when thoughts are continually being sucked out of your head. It means feeling that sometimes you are inside your head and visualizing yourself walking over your brain, or watching another girl wearing your clothes and carrying out actions as you think them. It means knowing that you are continually watched, that you can never succeed in life because the laws are all against you, and knowing that your ultimate destruction is never far away. So we're going to see how tormenting it is for the person when they experience these types of beliefs. Delusions. 3 core qualities. They're fixed, false beliefs, held despite what everyone else believes and obvious evidence to the contrary. What do I mean by that? It's a fixed belief. Fixed in that it holds true. I believe the CIA is bugging this room because I have special information that they want to get from me. And so they're putting bugs. There's bugs in the light fixtures. And that's what's happening. I don't change that. You go up, you rip the light apart, you show me no bugs, doesn't matter. Doesn't matter. They have technology, you wouldn't find it. It's fixed belief. I hold on to this. I can't logically be dissuaded from it. As I'm describing that one, we would all say it's clearly a false belief. And it doesn't matter if the rest of the people, all of you can tell me that's not true. I would not buy it. I'm not going to change. I'm going to hold on to it despite what everyone else will tell me, despite the evidence that you might try and present before me. I hold on to these delusional beliefs. The most common example I just gave you, paranoia, a paranoid delusion. I believe, again, that the CIA is bugging this room because I have information they want. I go out and I think that, these people that are looking at me funny, they're going to do something to try and hurt me. They don't have fears, anxieties will come into play with that kind of paranoia, suspiciousness. Obvious implications, right? How terrifying it would be to try and be in the world when this is my experience, right? With that level of paranoia. Other folks experience what are called grandiose delusions. Grandiose, meaning that they think they are on top of the world or beyond, really. Common one. I believe that I am the second coming of Jesus Christ. And I am here to impart my wisdom and to save all of you. And that's why I was put on this planet, to do that. I maintain I hold that belief. One thing to know about schizophrenia is that we're going to see it throughout the world, cross-culturally. What will change will be some of the themes. So while here I might be paranoid and think the CIA is bugging me, if I was in a tribal culture, I might believe that it was the spirit world doing this to me. Same symptom, just attributed in a different way. Same thing, I might hear a voice. Perhaps it's a voice from the spirit world as opposed to a person's voice. So some of the themes can change, but the symptoms will remain the same. And we can see that they're pretty terrifying. Because of that, the way that they're held so strongly, again, we don't want to just confront a delusion. One of the things that over time, when I work with somebody, can get to that place where helping them examine the evidence, if you will. So when something's happening, is this an assumption that they're making, or is it reality? And again, this can come after working with them for a while. They have some insight, some awareness of what's going on, that this is a symptom, but maybe still terrified about going out into the world. So I know I have paranoia. I know it's a symptom of my illness. Nevertheless, I'm still scared to go out in the world because I'm worried that I'm going to offend people and they're going to hurt me. And so we have to develop kind of soft kind of experiments. So we walk out into the world and see what happens. Let's say you go to if you're in a program and you go there and you say hello to 3 people. You go to a group and you say hello to 3 people. Let's test and see how they respond to you. And use that to help us see, is that your paranoia kicking in? Or are people really going to hurt you? So those are ways we're going to try. We'll talk more about some of the therapies next week to try and gently invite the person in there. One thing I'd like to invite is that you view these things as protective mechanisms, if you will, for the person. Albeit maladaptive, but they're kind of protective coping strategies. Person with schizophrenia, this illness, confusion, brain's not working properly, trying to make sense of things. I don't know how to go out and interact and be successful. I've had all these failures. These things are going on. Well, if I distance myself from the world and just say that you're against me, it's kind of almost like a protective thing that I can do for myself. So while logically we would want to invite such a coping strategy, invite you to think that in many ways that the symptoms like this can be protective for the person in facing the vulnerability of being out in the world and dealing with things. I invite that just so that it invites a little more compassion and empathy for what their experience is and why they might, how dangerous the world can be for them and why they would need such strategies. As I mentioned, we don't want to just confront these things. One other quote I want to read for you. One effect of the illness was that I heard voices, numerous voices, chatting, arguing, quarreling, telling me I should hurt myself or kill myself. I felt as if I was being put on a heavenly trial for misdeeds that I had done and was being held accountable by God. Other times I felt as if I was being pursued by the government for acts of disloyalty. I thought the voices I heard were being transmitted through the walls of my apartment, through the washer and dryer, and that those machines were talking and telling me things. I felt that the government agencies had planted transmitters and receivers in my apartment so that I could hear what they were saying and they could hear what I was saying. So again, you hear the torment of both the voices as well as those delusional beliefs. What you heard in there was an example of what we'll call a command hallucination. Command meaning the hallucination, the voice is telling the person to do something. And what you heard here is one of the more dangerous ones, of course, which is telling them to do something to hurt themselves or potentially hurt someone else. Command hallucinations. Oftentimes, probably the most common, those persecutory voices, right? Persecuting the person, telling them bad things about themselves, putting them down, and the like. People are out to get them, all that kind of stuff. Smaller percentage of folks will hear positive voices. Voices that are almost like their cheerleader. Voices that tell them good things about themselves. And if you can imagine, if you had somebody you thought was following you around all day, telling you great things about yourself, you probably wouldn't want to get rid of them. Wouldn't it be nice to have that kind of encouragement going on around you all the time? So when we hear about that, we start thinking about treatment. If I'm hearing positive voices, I'm not going to be too likely to want to take that medicine you're going to give me. I'm just going to get rid of that. And that's going to be the smaller minority. Most folks experience more the negative, those persecutory voices, or again, at more serious points, those command hallucinations, telling them to do something that can be very dangerous. William Wayne was an artist, and he suffered from schizophrenia. And William Wayne's best friend in the world was his cat. And he loved to draw pictures of his cat. And what we're seeing here is pictures that he drew of his cat over time as his illness became progressively worse. Became more psychotic, more disorganized in his thinking. Certainly if you look at the top left, it's clearly the picture of a cat. You go down to the bottom, and certainly the bottom right, you'd be hard-pressed to try and tell me that that was a cat. So imagine if your image of your best friend in the world now looks something like this. What you see throughout is artistic beauty and creativity. You can even see symmetry in those drawings. But the perception of reality greatly askew. Let's go back. Let's look at the first picture that he drew. The one he drew in his better days. And if you notice the eyes of that cat, you look into those big eyes, and you can see fear, perhaps even paranoia. And it just tells us and reminds us that even on his best days, for William Wayne, the world was a pretty terrifying place. And all too often, that's going to be the experience of the person with schizophrenia as well. As a small aside, as we move into the third area, I just want to mention briefly the impact of substances, drugs and alcohol abuse. We know that roughly half the folks with schizophrenia are going to experience an addiction. And from what I've described so far, it doesn't take too much wondering to know why that would be. Suffering of this kind leads us to want to do anything to get rid of it. What we see here on these slides are brain images of being high on PCP, methamphetamine, untreated schizophrenia, and the normal healthy brain. And if I can remind you of that wonderful song from Sesame Street, 3 of these things are kind of the same. 1 of these things is not like the others. And 3 of these things are kind of the same. What are we seeing here? The brain of the person on drugs really mimics the brain of the person with schizophrenia. Those impairments that we will see. So what happens when someone with this illness is abusing harsh drugs like speed or PCP is that it's adding fuel to the fire. Because we're just seeing that the damage from each of them is going to do this. Combined, we see why it can be so devastating. Again, we can understand why a person would turn to drugs and alcohol to want to try and cope with the devastation. Hopefully in treatment our goal is going to be to help ease that suffering and find them some new ways of coping. I want to move into the third area of the brain, which is the basal ganglia. And just to show you where that is in the brain. What we're seeing here is the basal ganglia. You see these structures that are there in the brain. A combination of structures. Now we're going a little bit deeper, right into the heart of the brain. Down in there. And some of the structures you'll see there at the heart of the brain. So what's going on in there? What's going on with this basal ganglia? Well, basal ganglia is what I'm going to dub the filter. So thus far we've got the executive, the reality checker, and now we've got the filter. One of the functions of the basal ganglia is that it inhibits unwanted sensory input. It filters out the irrelevant input. Regulates our level of arousal. And helps govern our concentration. Focus, concentration, arousal level. Right? And what we need in our brains is a good filter to do that. When we're focusing on something, if we're doing a task, right, we want to be able to block out the stuff that's not important in order to get it done. It just makes sense. But we know that this goes awry in folks with schizophrenia. As one person said, everything seems to grip my attention, although I'm not particularly interested in anything. As I'm speaking to you now, I can hear noises next door that I can't shut out, and it makes it difficult to concentrate on you. They don't interest me, but I find myself attending to them and wasting a lot of time. So that filter, not at work for the person, and so distracted by what's going on around them. Fancy term here, sensory gating. The filter acts like a gate for the senses. So information coming into the brain. Stuff I want to let in, we open the gate. Stuff we don't, we close the gate. Let's look at a study of sensory gating. Let's see what happens. Well, let's start at the bottom. The control, person without the mental illness. What we see when we expose them to a new sound. So we're fortunate tonight in this room that it's pretty quiet. When I first turn on the projector, maybe up in the front rows you can probably hear the hum of it. Now that I pointed out, maybe you can hear a little bit of the fan going. But if I first expose you to that, you'll notice it, but then your brain's going to filter it out. It's not that important. And what we'll see is that in the brain, you first hear it. It's new. The brain's supposed to notice new things. It does. So you see a little blip of activity there in the brain. But over time, it filters it out. Because I've learned that that's not an important thing to listen to. So even now as I turn it on again, I don't really even notice it because I've gotten accustomed to it. I get used to it. Healthy thing that should happen. What happens in schizophrenia? Well, something new comes in. Wow, real big blip of activity. More so. Over time, what happens? Filter's not working. Same blip of activity is going on in the brain. So, fans going. Maybe there's a hum of an air conditioner. There's cars driving by. All of these things now become distracting. As the person said, not that I'm interested in them, but I find myself paying attention to them. Many a time I've sat in my office and I'm talking with somebody, and someone walks by, a loud car goes by, and their head just turns, goes to the door where the hallway is, or looks out the window. Again, not because they're interested in it, or thankfully I know that, not that because they're bored with me, but because those sounds just distract them and take them away. Again, let's go back. I'm trying to be in school, I'm trying to work, I'm trying to learn something, and this is going on. It's going to be greatly, greatly difficult for me. If we look in the brain, and again, what we're going to see here is comparing a group of images of folks with the disorder and a group of folks without it. The controls on the top are without it. And what you'll see is that up on top, and where I'm looking is in this area here, where I'm seeing a lot of red in that area in those controls. And for the most part in this area, a lack of the red down in the folks with schizophrenia. And that's where we see the activity of this basal ganglia. Now, I said to you a little while ago, we can't diagnose schizophrenia based on a brain scan. And here's why. On top, I see a person without this illness, boy, they don't have that activity down there. Here's someone with schizophrenia. Basal ganglia working just fine. Can't use the scan to diagnose. What is it telling me? Well, if I had to take a guess, what I would say is for this person with schizophrenia, they're probably able to focus and concentrate just fine, thank you. And manage their arousal level. But probably what we'll see is they're going to have more of the symptoms of maybe the voices or the delusions, or more of those frontal lobe deficits that I was talking about. But not the problems here we're talking about. Whereas this person up here doesn't have schizophrenia, however, might have a difficult time focusing and concentrating. Easily distracted. Might even see another condition like attention deficit. So we'll see other things. So again, just want to highlight to you to know that we can use, in research it makes sense, because if I compare 100 of one group and 100 of another group, then those differences will stand out, but individually, they won't. Now I gave you another example before. I was talking about that stubbornness, and I said, someone who's lying in their room all day might tell you they're tired. They're drained, they have no energy, they're fatigued. And you have to think, well, how could this be? Well, got a research study that's going to help explain this for us. And this would be a research study that, if you were given the opportunity to participate, I think you'd love it, because the task in this research study is to rest. Right, so come be in my study, I'm going to pay you to rest. I think we'd all like to do that. So what happens when I invite you in and rest and I take pictures of your brain? Well, the bottom slides here show what happens. I see a lot of the blue. A lot of that activity just turning down. Up in that frontal lobe of the brain, this is a profile view, so up in the frontal lobe, what am I seeing? Well, I'm not seeing any of that fireball of activity. I'm seeing some yellow, there's some activity going on. You're not asleep here, you're just resting. So there's some activity, but not the fireball. So what's happening here? When you want to rest, your brain can cooperate with you. You can tone down and you can rest. And that's a good thing. Well, what happens up here in the person with schizophrenia? What am I seeing? Well, I'm seeing mostly the yellow throughout. I'm seeing some blue here, but an awful lot of the yellow. What is that saying to me? That's saying that there is still activity going on in the brain. It's not that fireball of activity, right, where the frontal lobe can really process and do things and get stuff done. But it's still going. And again, this is at rest. At rest. So, person lying in their bed all day, their brain's not taking a rest, their brain's still going and going. It's sort of like the car's in neutral, but the foot's still on the gas. You got a lot of energy being expended, but you're really going nowhere. You're wasting a lot of energy. Not by choice, of course, but that's what's happening to the person. A lot of energy being expended and unable to get anything done. Now, this is going to sound a little different than most of what I've told you about tonight, because most slides I've shown you tonight, I've talked about a lack of activity in the brain scan of the person with schizophrenia and higher level of activity in the person without a mental illness. Right? I wanted to see the frontal lobe of a fireball of activity. I wanted to see this filter at work, able to filter things out. But here I'm showing you the opposite. I'm showing you that there's too much activity when there should be less. And so the way I can invite you to understand that, give you kind of two ways of seeing it. First, just kind of a little picture example, if you will. For most of us, our energy level is here. I give you an activity. You fire up your energy level way up here. Fireball of activity in the brain. You rest. You can come way down here. Low activity level in the brain. Here's our baseline. Person with schizophrenia. I give you an activity to do. You don't have the fireball of activity. Maybe you get some activity, but certainly not enough, like I'd want way up here. But now I tell you to rest. And you can't really turn it down either. You can turn down a little bit, but you're right down here. Not way down low. So we don't get that brain's not able to kind of fire up and cool down when it needs to happen. It's going to just always kind of be rugged. Again, kind of like in neutral, but with the gas going. Nothing really is happening. Energy expended. You know, to the outside world, this can be confusing. So imagine tonight, you go home and you're hungry and you go into your kitchen. And I hope in your kitchen when you get home, it's about 72 degrees, room temperature in that kitchen. But if you're hungry and you want to cook something, you take some food and you put it into this one little section of your kitchen, which we'll call the oven, and you heat that oven up to 350. And when you heat that oven up to 350, you cook something. The entire room is 72, the oven is 350. That's the way it should work. Your brain should work in a similar way. You want it, if you will, at room temperature. You want it to be at 72. But then when you need to get an activity done, you want part of it to fire up and get the job done. Just like the oven is getting your food cooked. Now, let's say you're at the other end of the house and you can see me over there and you see that happening. Now I want to give you a different scenario. And this scenario, I'm at the end of the house and I look over and I see you come home and you walk into that kitchen and you get into that kitchen tonight. It's 110 degrees in your kitchen. And you're hungry and you want to try and cook something. It'll be hot. You're probably going to get tired pretty quickly. I'm watching you from afar and I'm looking, but you're moving awfully slow. But you're going to take that food, you pop it into that oven, you try and crank up the oven, and the oven only goes up to 150. So your food's not getting cooked either. I'm at the other end of the house, I'm looking over, I'm like, what are you doing? You're not getting anything done. Are you lazy? You're moving really slow. I can really easily misattribute what's going on without the understanding of what the environment is like in your kitchen. We need to understand what the environment is like for the person living in their body, what they're experiencing in their brain. This activity going but not able to get things done. Very frustrating aspect of this illness. What does the person often do? They'll make what we'll call ineffective and expensive attempts to manage the anxiety. They try to do things to block out the world. Persons wear earphones all the time, block out voices. Go around humming. Despite the fact there's other people living there trying to have conversations, they're walking through humming and listening to something. They'll pace up and down, all that energy. Can't sit still. Call these ineffective because they really aren't managing the condition. They aren't able to lower the symptoms. And I call them expensive because they really rob the person of their goals and dreams. And part of what we'll talk about next week with treatment is we can provide helpful coping strategies, maybe some different ways of managing that anxiety. We can really help the person to be able to move forward and better manage their condition. So last structure I want to mention to you is the limbic system. Now, as we look at the limbic system, we're going to see a group of structures. Cingulate gyrus. This almond-shaped structure is called the amygdala. Remember that one? We're going to come back to that one in a moment. Remember, this area as well is going to be really implicated when we start talking about trauma and PTSD and anxiety. For our purposes tonight, we're looking at some different functions of the limbic system. Again, the deeper structure down in the brain. What are we going to be talking about here tonight? Well, I'm going to dub the limbic system the switchboard operator. So we've got an executive, a reality checker, a filter, and now a switchboard operator. Now when I say a switchboard operator, you might have to rack your brain a little bit to think of like old black and white movies of what a switchboard looked like, when wires were taken from one section and put into another. And the operator had to do that to connect the call to the right person. Put it in the wrong place, call's being connected to the wrong person. That's what would happen. That's a good switchboard operator. What does the switchboard operator do? Well, in the brain, these connections are understanding emotional events, linking my current perception to past memories, and the ability to learn from experience. I'm linking a lot of past and present here, and understanding the emotional context of events. First, to show you the more severe case where we'll see structural damage. Here I'd highlight, for example, down here, this almond-shaped now cavity where the amygdala should be. And this, again, very, very severe case. Worst, probably 1% of schizophrenia. We actually see a missing amygdala in that structure where, again, we should see it over here. More likely than this, however, in most cases with schizophrenia, is going to be that functional damage I talked about. And if you think back to the beginning of our lecture when I talked about cortical pruning going awry, that's what we're going to see here. We look on the top, healthier brain, lack of mental illness. We see strong neurons. And so if a message comes in up top here, I know exactly where it's going to come out. It's going to come down here and get sent out. Again, looks like almost like a healthy root of a plant with leaves flowing out. Schizophrenia, cortical pruning going awry. We see that tangled web. Down here, all the neurons tangled, right? The weeds in the garden. Message comes in up here. Where's it going to come out? Anybody's guess along this line. Anybody can come out anywhere. Right? Tangled up. Symptom we will see when this occurs is what is known as a loose association. A loose association. Right? Things become loosely associated in my mind. I'll give you a great example, an example that you could probably follow. I was sitting once in a clubhouse program talking with one guy, and he was just talking about what he's been doing. And another guy with schizophrenia came up, and he sat next to us. And the gentleman talking to me said that he was out in the garden, and he was working in his garden, actually. He was telling me about that. And his plans, and he was saying how he hammered stakes into the ground. This other guy said, steaks, oh, steaks in the garden. It's like steak for dinner. You know, I had chicken for dinner. Kentucky Fried Chicken, the Colonel. I was in the Army once. sound, right? You can see, and the bing, 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 bing. Now in that example, you could follow, right? Steak to the steak we eat. Eating steak to eating chicken. Chicken, Kentucky Fried Chicken. Colonel Sanders, Kentucky Fried Chicken, Colonel Army. We can see that progression being made. Usually we don't see that progression. Usually we just hear this person's here talking about steaks, and the person next to me says, I was in the Army once. And we wonder, where did that come from? What does that mean? And one of our mistakes might be, there's a deeper meaning behind this. There's some deeper meaning. I have to figure out what this means. And what I would tell you is that there is a deeper meaning. And the deeper meaning is that somewhere deep down in the cortex of the brain, there's something that goes awry. And that's why this connection is being made. Let's not psychoanalyze it. Let's more just see that it's symptomatic of the condition. When associations become very severe, we can see a symptom called a word salad. And word salad, just think of words tossed in a salad. So the person might just say things like steak, blue, army, girlfriend, computer, just random words that just start getting mixed together. It can be incoherent. Get a more severe form of those loose associations in thinking. We'll see these sort of on a continuum, right? On a continuum. I know with some folks I work with, their associations, but sometimes in the milder form, to help us differentiate, we don't call them associations that sound more like severe symptoms. We just say, we notice you're giving cues greater meaning. So I've given some cue I've gotten around me, I'm giving too much meaning to it. So, for example, I just look and somebody turned away from me, and they didn't like me. Maybe when I stop and think, okay, wait, just a cue, they just turned away. Maybe it wasn't about me. Maybe I learned not to personalize those types of things. We'll talk about treatment more next week and how we do that with cognitive behavioral therapy. But this is where we see it in the brain. One of the other symptoms, talk about learning from past experience. Imagine you turn on your computer and you don't have access to your stored files. Imagine having to recreate things every time you turn on your computer. If I don't have access to that. Oftentimes, with schizophrenia, there is going to be some difficulty accessing that. In our life, imagine if you don't have good access to your memories. If I ask you who are you? Tell me about yourself. You're probably going to access a lot of memories. Tell me about some of your experiences that make you up as a person, how you might describe yourself. Without access to that, you're going to have a hard time knowing your own identity. How would you describe who you are? Oftentimes in schizophrenia, folks have a hard time describing their own identity. And we can see it here, because of that difficulty accessing some of those things. So let me just put together a little bit of our learning from tonight, and then we'll open up for a few questions. First, schizophrenia. No fault, biologically based, family illness. Has specific functional deficits which can be seen in the brain. We talked about 4 areas to highlight really all the major symptoms of schizophrenia. The frontal lobe, known as the executive, all those core mental processes that separate us from every other animal in the animal kingdom. Planning and organization, problem solving, empathy, judgment, organization, all of that good stuff. We talked about the temporal lobe, dubbed it the reality checker, and saw that the temporal lobe is the seat for the disturbing hallucinations and delusions experienced by the person. We also looked into the basal ganglia, which we dubbed the filter, because it helps govern arousal, concentration, focus, block out irrelevant stimuli. And then lastly, we took a look at the limbic system, which for our purposes we dubbed the switchboard, because of its ability to link past memories to the present, emotional events to the present. A little teaser I want to give you for next week when we start talking about treatment. Gray bars indicate current level of functioning for folks with schizophrenia. Roughly 50% of folks with this disorder lead what I'll call a dependent passive life. Completely dependent upon family, board and care, an institution, and leading a very passive life. Not going out, kind of living, loving, learning as we all want to do in life. About 20% are leading what's called a dependent active, another 20% semi-independent. What do we mean here? Perhaps still dependent, family, board and care, but able to go out and start doing some things in life. Participating in groups and activities, socializing, having friends, doing things. Semi-independent, perhaps volunteering, working part-time, doing some things. And about only 10% of folks with this disorder are fully independent and self-supported. The gold bars, however, indicate the best possible treatment for folks with schizophrenia, if we provide them with what we'll call the gold standard of treatment. If we do that, we know that only about 10% of folks would have to live a real dependent passive life. And those are going to be the folks for whom there's going to be a lot of the structural damage to the brain, that even with the best possible treatment, minimal to limited effects. Now, about 60% of folks are going to be able to lead more dependent, active, semi-independent lives. Again, the impairments of the brain, not fully independent, but able to kind of go out there more, getting back out in their community, finding meaning and purpose, doing things that are important to them, participating in social activities, school, work, moving forward, and roughly 30% can actually become independent. So as you look at this, important thing to take away, a couple things. One, with treatment we can greatly improve the quality of life of folks. But I also want you to see that even right now at its best, the goal here isn't that everybody's way in this right column. I mean, in the big picture, ultimately over time, yeah, that would be our goal. But day to day, right now, our goal isn't to get the person all the way to the right. You might think, where's my relative right now? And maybe our goal is, can we help them move one step further to the right on this chart? A little bit further. Can we help them in their recovery move forward? Because, again, not everyone will get to this place. Not everyone will get to this place. Can we help them just do a little bit more? One step more. And if we can do that, we're doing good. So recovery, I will say, is not only possible, probably, if we can provide the optimal treatment. And what that's going to include, and what you're going to hear about next week and beyond, medication, psychosocial rehabilitation, and family support. So I hope that teased you enough to want to come back again next week to learn more about these treatments. With that, let me pause and open up for a few questions. We have about 5 minutes or so, so I'll be happy to take some questions. Yes?
I think a little bit, the title tonight was also The Beautiful Mind, about how someone like John Nash would be so schizophrenic and yet be such a savant, for lack of a better word.
Great question. The question referred to what our title for tonight, Inside the Beautiful Mind of Schizophrenia. Those of you who saw that movie, A Beautiful Mind, know that John Nash, winner, developed certainly brilliant ideas, yet he also had schizophrenia. Schizophrenia doesn't impair the intelligence of the person. Now, they're not able to perform tasks and do as well, so it may look like they're not as smart, but intelligence remains intact. So you can see someone like John Nash do some great, amazing things, even while he has this illness there wreaking havoc on his mind. Developing these amazing theorems and stuff while believing that he was being followed and all the like was going on. And certainly his story can be a great inspiration for us. Also the reminder of what it's like to have someone in your corner, that supportive person. His wife stood by him throughout that. So again, intelligence not taken away by this disorder. Creativity. we'll also see a lot of creativity in schizophrenia, not taken away by the disorder. So again, it invites us to think that while someone may have some challenges in some of the ways that society tells us success is supposed to be, 40-hour-a-week jobs, there are many, many other ways to find and identify success. And we're invited to think about that, expand our way of thinking about that. How we can tap into creativity is certainly one way we expand that window of what success means. Yes?
Could you say something a little bit about late in life onset of schizophrenia?
Question is just about late in life onset of schizophrenia. Generally speaking, the later the illness hits, the less severe form of the disorder is. Childhood schizophrenia will typically be a more severe form of the illness. For reasons I'd say are pretty much unclear why, we know it can occur a bit later in life. When it does, we'll still see same core symptoms of the disorder occurring. Again, statistically they'll be a little bit milder, but they're going to be the same core symptoms we're going to see. And so it'll invite us into the same elements of treatment with the disorder that you'll hear about next week. Any other questions? Take one more. Yes.
I attended a meeting where John Nash was presented, and also they talked about schizophrenia. And one of the things they did say was that there's a high correlation between being gifted, high IQ, and schizophrenia. Have you heard anything of that stuff?
Just the question referred to a correlation between being highly gifted and schizophrenia.
Right.
And again, my just understanding is that illness does not per se impair the intelligence, so that we will see folks who are gifted with schizophrenia. I'm not as familiar in terms of there being higher rates of it in folks with schizophrenia or not. Some research has said there is. I don't know if we know much into per se why that would be. Other than that, again, the intelligence remains intact.
Is there a difference between having schizophrenia as a teenager as far as cure compared to having late onset schizophrenia?
Again, question is if it's difficult. Is it different if there is earlier onset, adolescence versus later onset? Again, the main difference we find is that the severity, the earlier it hits, the greater the severity of it. The course of it, in terms of the main core symptoms, will be roughly the same. If you just kind of put it into life, I mean, for most of us, our teens and 20s are going to be more turbulent times of life as opposed to our 40s and 50s. So it just makes sense that, yeah, it's going to be, just illness aside, more turbulent during those teens and 20s, and the illness is going to make it even worse. So there was one more hand in the back I'll take before we have to wind up. Yes?
Do you find short-term memory loss more prevalent in schizophrenia versus bipolar? Because my son has been diagnosed with everything. He has incredible short-term, but his long-term, going back, is phenomenal.
So the question refers to short-term memory loss versus long-term memory loss. Also, any differences between bipolar disorder and schizophrenia in that. I'm not familiar in terms of differences between the two, but yes, we do see the short-term memory loss. We do see memory loss in both. The other thing that happens with both of those is in real psychotic episodes, real manic episodes, we will see memory loss of what happens. So the person coming out of it, once they're stabilized, even the person with awareness of their condition may not remember what happened at their worst moments. And there's a partial blessing in that, if you can imagine that, right? That I don't have to remember what things were like when I was at my worst. The downside to that could be if I'm lacking some insight and I don't remember those periods, then I'm not going to buy what you're trying to tell me. So I can be frustrated with that as well. So yes, memory will get impacted by the disorder. So with that, I want to honor the time and thank you for being here. If you have further questions, feel free to come up and speak to me afterwards. And I look forward to hopefully seeing you next week when we talk about treatment for the disorder and how we can really help improve quality of life for folks suffering with it. Thank you.